third year resident.
Oh, okay, wonderful. So we are going to cover the leftover from the cranial nerve from last time. It's the 9, 10, 11, and 12, the caudal cranial nerves. And we are going to have a Rhoton session on detailed anatomy. And then Pablo will give us some cases. We'll try to interact together about some clinical aspects of it. Okay, go ahead, Dr. Omar Siddiqui.
Hi, greetings everyone. I am Dr. Uzair Ahmed Siddiqui from Liaquat National Hospital and Medical College. I am a neurosurgery resident under Professor Salman Sharif. I am going to present the anatomy of the lower 4 cranial nerves. But before we proceed to the anatomy of the cranial nerves, let us have an overview of brainstem, because brainstem is the place from where all these cranial nerves are going to arise, and obviously we are going to have an overview of the neurovascular complexes of the brainstem as well. Now we can see an anterior-posterior view of this beautiful cadaveric brainstem along with the cerebellum. So here we can see the highlighted portion is the brainstem, the upper portion is the pons, and the lower portion is medulla oblongata. And this is the folliculus of the cerebellum on the other side. And then we can obviously appreciate the cerebellum over here. This is again pons highlighted. This is medulla oblongata. This is the pontomedullary sulcus. This is the lateral portion of the pons. And now this is pyramid of the medulla, and this is olive of the medulla. This is the CP angle. And now this is the abducens nerve, or the 6th cranial nerve arising from the pontomedullary sulcus. And now this highlighted one is the 7th cranial nerve. And this is the 8th cranial nerve. And now the 9th cranial nerve arising from the other side behind the post-olivary sulcus. And then there is 10th cranial nerve, our vagus nerve, and then spinal accessory nerve that actually arises from the initial 5 segments of the cervical spinal cord, and then ascends upwards through the foramen magnum laterally to exit through the jugular foramen. And then we have the hypoglossal nerve rootlets arising from the other sides. Now this is a lateral view of a cadaveric brainstem along with the cerebellum. We can appreciate this is the midbrain, this is pons, and this is medulla oblongata, and obviously behind it, capturing it from the behind is cerebellum. So this is dorsal medullary sulcus, this is post-olivary sulcus, and this anterolateral sulcus of the medulla oblongata. And we can appreciate this is the 3rd cranial nerve arising from midbrain. This is the 4th cranial nerve, and then we can appreciate the highlighted one is the trigeminal nerve arising from the pons, and then this is the 6th cranial nerve arising from the pontomedullary sulcus as seen in the lateral view.
Sorry, Uzair, can you go back and do the cranial nerves, show the cranial nerves again, because you just need to show it with a pointer as well.
Okay, let me try it. Can you appreciate the highlighted portion, sir?
Yes.
So again, these are the sulcus of the medulla oblongata. Then this highlighted portion is 3rd cranial nerve, oculomotor, from the ventral aspect of the midbrain. And then we have trochlear from the midbrain. Then we have trigeminal arising from the pons. And then this one is 6th cranial nerve from the pontomedullary sulcus. Again, this is anterior-posterior view of the brainstem. Like explained earlier, we are going to have a zoom in on the right anterior portion. So here we can appreciate again, this is pons, this is medulla oblongata, this is folliculus, and this is choroid plexus. And we can now appreciate this is 6th cranial nerve, this one is 7, this one is 8, and our primary focus here are on 9, 10, 11, and 12. So this is basically again CP angle. This is 7th cranial nerve. This one is 8th cranial nerve. This one that is being retracted by the instrument is the 9th cranial nerve, just near its origin. Now these are the rootlets of the vagus, soon are going to fuse to form a single trunk laterally. And this is the spinal accessory nerve, which has actually arisen from the spinal canal through the foramen magnum upwards. to again exit it through jugular foramen, and this one is hypoglossal somewhere. Unfortunately, I cannot highlight it. So now proceeding to the neurovascular complexes. Obviously, this diagram is a little bit difficult, just like a bunch of spaghetti. But meanwhile, we are going to make it easy to learn and remember. This is again anterior view of the right CP angle. So before we proceed to the neurovascular structure and try to remember and memorize it, let's have a schematic look at the neurovascular complexes of the brainstem and the cerebellum. Like I explained earlier, brainstem is captured from behind cerebellum. So cerebellum is connected to each of the three parts of the brainstem through cerebellar peduncles. So in the upper portion, we have the midbrain that is connected to cerebellum with the help of superior cerebellar peduncle. Similarly, we have the pons that is connected to cerebellum with the help of middle cerebellar peduncle, and then we have the lower portion of the brainstem that is medulla oblongata that is connected to cerebellum with the help of inferior cerebellar peduncle. So each of these complexes have their particular arterial supply and cranial nerves along with it. So we know that in the upper complex that is composed of superior cerebellar peduncle and midbrain, we have a fissure that is cerebello-mesencephalic fissure. So these fissures are responsible for the traversing or provide the pathway for the anatomy and the cranial nerves that exit through these fissures to go laterally and exit the cranium later on. So in the upper complex, in the cerebello-mesencephalic fissure, we know that there is superior cerebellar artery, and we have three cranial nerves. These are 3, 4, and 5. So now proceeding to the middle complex, we know that it is between pons and connected to cerebellum with the middle cerebellar peduncle, and the fissure that is enclosed, that is formed by the fusion of pons and middle cerebellar peduncle, is cerebello-pontine fissure, and it is responsible for providing the pathway to anterior inferior cerebellar artery and the cranial nerves 6, 7, and 8. So, and then we have the lower complex that is our primary target today, is composed of cerebello-medullary fissure that is formed when medulla is reached by cerebellum from the inferior cerebellar peduncle. So contents of the cerebello-medullary fissure will be posterior inferior cerebellar artery and the lower 4 cranial nerves 9, 10, 11, and 12. That is going to be our focus of presentation today. So this is the schematic diagram. Now moving again to the diagram we discussed earlier. So we are going to highlight each of the vessels and the nerves origin one by one. So we have an overview of the anatomy. This is the pons, this is flocculus, and this is some part of medulla oblongata. Remember, it is a right antero-posterior view. Now this highlighted portion is a right vertebral artery that is going to join the left vertebral artery and form the basilar artery that is highlighted in this slide. Now this is pica that is related to cerebello-medullary fissure and the lower 4 cranial nerves. Then we have anterior inferior cerebellar artery, and that is related to cranial nerve 8, 7, and 6. And then we have superior cerebellar artery that is related to the midbrain and the cerebello-mesencephalic fissure and the cranial nerves 3, 4, and 5. So this is trigeminal nerve close to superior cerebellar artery. This is a 6th cranial nerve, abducent nerve, arising from the pontomedullary sulcus. Obviously, that cannot be appreciated in the bunch of these vessels. Then we have the 7th cranial nerve, the facial nerve. Then we have somewhat thick fibers of 8th cranial nerve originating from the pons, and then we have this small 9th cranial nerve. Hopefully you can appreciate this highlighted yellow portion. Then we have the 10th cranial nerve, the vagus nerve. Then we have the spinal accessory nerve that actually lies in the spinal cord. Initial 5 segments arise in, traverse the foramen magnum, and then again going to exit through the jugular foramen. And these one are the small rootlets of the hypoglossal nerve. So again, repeating it. This is pons. This is flocculus of the cerebellum. This is some part of the medulla oblongata. Then we have vertebral artery. This one is basilar artery. This one is spica. And this one is anterior inferior cerebellar artery. And this one is superior cerebellar artery. And these highlighted portion of fiber trunks are the trigeminal nerve. This one is abducens nerve. This one is 7th or the facial nerve, and this one is vestibulocochlear complex. And then we have 9th cranial nerve, the glossopharyngeal. Then we have the trunk of vagus nerve. Then we have 11th nerve, and these are the rootlets of the hypoglossal nerve. Now, this is again anterior view of the right portion, anterior-posterior view of right portion of cranial nerve, showing the pons, medulla oblongata again. Now we are going to superimpose vasculature on it. So this is again, this diagram is again superimposed by the vasculature. We are going to identify it one by one. So this is again pons. This is medulla oblongata. This one is flocculus, and then choroid plexus obviously. Then this is posterior inferior cerebellar artery, and then we have anterior inferior cerebellar artery. This one is 9th cranial nerve. Obviously, we can see the close proximity of it with the posterior inferior cerebellar artery. Like if you'd like to remember the lower neurovascular complex. Posterior inferior cerebellar artery, 9th cranial nerve, the 10th cranial nerve. This one is 11th cranial nerve and the 12th cranial nerves. So now moving on, hopefully everyone can understand and memorize it. And now, as we have covered the gross anatomy and neurovasculature arranged with the brainstem, before proceeding to the actual cranial nerves, I would like to have a brief overview of the brainstem nuclei that are responsible for the outflex and the sensory innervation from the respective part of the head and neck. Now,
sorry to interrupt you. Sorry to interrupt you, Dr. Reza. Can you go back to the slide with the vessel? And I'd like you to say the origin of the pica, from where it's coming. You mentioned the vessel, but you didn't specify from where it's coming, and show it.
Okay, sir. So this is arising from some part of the vertebral artery. It has 3 different components: tensomedullary. So this is originating
the
from.
Next picture show it better.
Sorry, sir.
The next slide show it better with the vessel.
Yes.
Continue.
Yes, I'm going to show a zoom-in version of this slide. Yes.
Sure, this is a good picture where the origin.
So from somewhere here.
Yes.
Yes, sir.
Okay. Very good.
And then we have anterior inferior cerebellar from the basilar. So now coming to the brainstem nuclei. So these is the diagrammatic representation of the cranial nerves. We all are familiar in our medical school. Cranial nerve 1 and 2 arise from the forebrain, then 3 and 4 from the midbrain, 5, 6, 7, 8 from the pons, and 9, 10, 11, 12 from the medulla oblongata. I am not going to emphasize on the individual function because we are going to have a detailed overview of the lower 4 cranial nerves later on. So before we actually discuss the functions and anatomy of the cranial nerve, let's divide the brainstem nuclei, or you can see, let's divide the fibers that carry sensation from the head and neck and the fibers that carry the motor outflow or the parasympathetic outflow. So the cranial nerve can be divided according to modalities or the functions in 6 distinct types. We have general somatic efferent. General somatic efferent refers to all the muscles in the head and neck that originate from the somites. This includes uh, extraocular muscles, some muscles of tongue, intrinsic and extrinsic muscles of the tongue. We can say that the general somatic efferent is the somatic motor responsible for an outflow that innervates muscles that develop from the somites. Then we have the muscles that originate from the branchial arches. These includes muscles of mastication and the muscles of facial expression and the muscles like sternocleidomastoid and trapezius. These include spatial visceral, not including sternocleidomastoid and trapezius. These are basically somites. So again, spatial visceral efferent, just to remember it, it innervates the muscles that develop from the branchial arches. It includes muscles of mastication and muscles of facial expression. Then we have general visceral efferent. This is the responsible for the parasympathetic outflow to the viscera, to the oculomotor and salivatory nucleus and the things like that. Then we have the sensory component that includes general somatic efferent that transmit somatic sensation from the head, neck, sinuses, and the meninges. Then we have visceral afferent that transmit visceral information but not pain impulses, mainly through the 9th and 10th cranial nerve. Then we have spatial afferent for the spatial senses like vision, smell, taste, balance, and hearing information. Now moving on to the next slide. Thank you, Imad. Can you remove this controller? It's obstructing the view. Yeah, this is fine. Okay, now this is embryonic representation of the arrangement of the cranial nerve nuclei inside the brainstem. On the left side, we can appreciate the motor columns. On the right side, we can appreciate the sensory column. This is only the pictorial representation. So here we can see the red color that goes as general somatic efferent. This is responsible for the motor movements of the extraocular muscles and all the muscles that develop from the somite. So we know the cranial nerve 3, cranial nerve 4, and cranial nerve 6, all of which supply the extraocular muscles developed from the somite are going to be controlled by these nerves, and their nuclei corresponds to the general somatic efferent. Then we have medulla oblongata that obviously contains the nucleus for the hypoglossal nerve and controls the intrinsic and extrinsic muscles of the tongue. Then we have spatial visceral efferent for all the muscles that develop from the branchial arches. So we have 5th cranial nerve, that is trigeminal for the muscles of mastication, motor component, and then we have facial nerve for the muscles of facial expression. Then we have 9, 10, 11 cranial nerve having a nucleus as nucleus ambiguous that we are going to discuss in detail. Then we have general visceral efferent, that is the oculomotor responsible for the oculomotor or pupillary reflex. Then we have salivatory nucleus, and then we have dorsal nucleus of the vagus that is responsible for the parasympathetic outflow till the neck, thorax, and the abdominal viscera. Now coming to the sensory. So first of all, we have general somatic efferent. We can see here a single color coding here that represent the trigeminal nerve elongated nucleus and its different parts. This is the mesencephalic nucleus, this is acute sensory nucleus, and this is spinal nucleus of the trigeminal nerve. So it is responsible for carrying sensation all the way from the head and neck through the trigeminal nerve, through the general somatic afferent fibers. Then we have spatial visceral efferent and general visceral efferent, and all these fibers go all the way up to the nucleus of tractus solitarius that is responsible for the taste sensation. And then we have spatial sensory afferent that is responsible for hearing and balancing, and we can appreciate this vestibulocochlear complex lies, some part of it lies in the pons and some part of it lies in the medulla, and is responsible for hearing and balancing input. Now this is again this is again a view of brainstem schematic diagram showing sensory nuclei on the left side and motor nuclei on the right side. So we can appreciate this one is the oculomotor nucleus donated by red color. This is the trochlear nucleus. This one is abducens nucleus, and this one is hypoglossal nucleus. Like I explained earlier, these are responsible for the general somatic efferent component and are going to control the muscles that originate from somites. Then we have spatial visceral efferent that are responsible to supply the muscles that originate from the branchial arches. So we have the motor nucleus of trigeminal nerve that is responsible for the muscles of mastication. Then we have the motor nucleus of facial nerve that is responsible for the muscles of facial expression. Then we have the nucleus ambiguous for the stylopharyngeal that is supplied by the glossopharyngeal. And now coming to the sensory part, we have the trigeminal nerve. This is the mesencephalic nucleus of the trigeminal nerve. This is chief sensory nucleus of the trigeminal nerve, and this is nucleus of the spinal tract of trigeminal nerve. So this is responsible for the somatic afferent from the head and neck region. Then we have the nucleus of tractus solitarius responsible mainly for the taste sensation, and then we have vestibular and cochlear nuclei that is consisting pontine part and the medullary part as well. So this is again brief summary. This is the general somatic efferent column like I discussed earlier. This is responsible nuclei are oculomotor nucleus, trochlear nucleus, abducens nucleus, and the hypoglossal nucleus. Then we have spatial visceral efferent column for the muscles that originate from the brachial arches. We have motor nucleus of trigeminal nerve, motor nucleus of facial nerve, and the nucleus ambiguous. Then we have general visceral efferent, mainly the parasympathetic outflow. This is Edinger Westphal nucleus for the pupillary reflex. Then we have lacrimatory nucleus for the lacrimation. Then we have superior salivatory and inferior salivatory that are going to provide parasympathetic outflow to the organs of salivation. And then we have dorsal nucleus of the vagus nerve that gives rise to the fibers that supplies as far as abdomen to the viscera. Then we have general visceral efferent, the nucleus of the solitarius tract, specialized cells responsible for taste sensation. Then we have general somatic afferent, for which solely nucleus of trigeminal nerve is responsible with all its three parts. Then we have spatial sensory afferent, the vestibular nuclei and the cochlear nuclei responsible for balancing and hearing respectively. So now we have discussed the brainstem nuclei and the functional components. Now moving further, so we have our focus on glossopharyngeal nerve. We are going to discuss the functions of glossopharyngeal nerve, its supply, its anatomy, origin, and radiology. So here again we have a brainstem, different views showing the nuclei. So the color coding, if you follow, we have the nucleus ambiguous that provides the branchial motor fibers to the only muscle that is stylopharyngeus. So this one is nucleus ambiguous. It is going to give rise to the fibers of spatial visceral efferent. Then we have inferior salivatory nucleus denoted by the green color, responsible for the parasympathetic outflow to the head and neck. And then we have nucleus solitarius that is responsible to receive visceral sensory fibers that contains the taste sensation from the posterior 1/3 of the tongue. So again, having functions, we have spatial visceral efferent, like discussed earlier, nucleus ambiguous, going to supply through going to supply the stylopharyngeus. Then we have general visceral efferent arising from the inferior salivatory nucleus, relays in the otic ganglion, provide postganglionic parasympathetic fiber that is going to provide parasympathetic outflow to the parotid via auriculotemporal nerve. Then we have general sensory efferent that carries a sensation from the external layer, posterior 1/3 of the tongue, soft palate, nasopharynx, and mastoid. Then we have visceral efferent. So this one is important. We are going to discuss. It takes sensation from the carotid body and the carotid sinus in the neck. Then we have spatial afferent that carries stays from the posterior 1/3 of the tongue all the way to the nucleus of rectus solitarius. So again, this is a schematic diagram. This is inferior salivatory nucleus, noted by the red color, responsible for the parasympathetic outflow. Here is going to the tympanic plexus, then otic ganglion, and providing parasympathetic flow for salivation to the parotid gland. Then these are the blue fiber that carries general somatic afferent all the way to the solitary nucleus. And then we have this nucleus ambiguous going to provide the only muscle, that is stylopharyngeus. So anatomy, like we discussed earlier and saw in cadaveric model, it arises from the post-olivary sulcus of the medulla oblongata, travels in the subarachnoid space in the cerebellomedullary system. Like I discussed earlier, the lower complex comprised of the inferior cerebellar peduncle, medulla, and the cerebellomedullary system. So whenever we are going to discuss the pathway of these lower 4 cranial nerves, we will have cerebellomedullary system in account. Then it goes into the jugular foramen through the pars nervosa. We are going to discuss jugular foramen later on, and then exits into the pharynx into the carotid space. So again, we have anterior, posterior view of brain stem, cadaveric model. The highlighted one is the glossopharyngeal nerve. This is zoom in view. And then this is anterior posterior dissection in order to visualize the brain stem. We have removed the clival areas somewhere here. So we have this vertebral artery going to form into the basilar artery. Then this one is glossopharyngeal nerve arising from the post-olivary sulcus, and this region would be the cerebellomedullary system, and as we learned earlier, this one would be the pica. So on the other side, we can appreciate the glossopharyngeal nerve. Then beneath it, we have vagus nerve. Then we have spinal accessory. Then we have hypoglossal nerve in the hypoglossal canal. So this is infero superior view of the base of skull, showing the region of the jugular foramen. Now this is the CT scan through the same level. Here we can appreciate the clivus. The CC donates to carotid canal. And then this portion, all of this is jugular foramen, and we can appreciate the jugular spine here. So this more medial part is pars nervosa, through which the glossopharyngeal is going to pass. And then we have the pars vascularis, through which the vagus and spinal accessory nerve traverse. So coming to the anatomy of the jugular foramen, here we can appreciate the CT scan view. So this is the foramen lacerum. This is carotid canal. This region is pars nervosa. This is jugular spine, and this region is pars vascularis. Now coming to the schematic diagram, we can see the inferior petrosal sinus, when it passes through the jugular foramen, is going to become internal jugular vein. So this small fibrous septum is dividing this jugular foramen into two components, that is pars nervosa, and this one is pars vascularis. In the pars nervosa, we can appreciate the glossopharyngeal nerve. So one more thing I would like to mention is that glossopharyngeal nerve, before exiting the skull, give rise to the Jacobson's nerve or the auditory branch. carries the sensation from the air. This is pars nervosa, this is fibrous septum, then this is vagus nerve, this is posterior meningeal artery, this is spinal accessory nerve. All these nerves exit the cranium through the jugular foramen.
Could you please raise your voice? Just increase the volume. Thank you.
Okay, sir. So again, this is a schematic diagram of the jugular foramen. Here we can appreciate this is the fibrous septum dividing the jugular foramen in two parts, that is pars nervosa and pars vascularis. In the pars nervosa, we have 9 cranial nerves, that is before exiting the skull, giving rise to tympanic branch or the nerve of the Jacobson. Then we have the pars vascularis that contains the internal jugular vein, that is basically the continuation of inferior petrosal sinus as it passes through the jugular foramen. Then its contents are the 10th and 11th cranial nerve. So this is actual cadaveric model of the jugular foramen. So this is the region of jugular foramen. This is the fibrous septum that we discussed earlier. This one is glossopharyngeal meatus, through which the glossopharyngeal nerve is going to exit the skull. This one is the vagal meatus, through which the vagus and spinal accessory nerve are going to exit the skull. So this is glossopharyngeal nerve exiting through the jugular foramen. This one is vagus nerve exiting through the jugular foramen, and this one is spinal accessory nerve. Now this is the infero-superior view of the jugular foramen after these nerves are exit from the above downwards, exiting the cranial cavity. So this is internal jugular vein. This small nerve, hopefully you can appreciate, I've highlighted it. This is glossopharyngeal nerve that is exiting the jugular foramen, so it's part of pars nervosa. Then we have the vagus nerve, and then we have spinal accessory nerve exiting the jugular foramen. Now this view, this highlighted nerve is glossopharyngeal after it has exited the cranial cavity, and it is going to supply through this branch to the carotid body and the carotid sinus here. So this is all about the anatomical course of the glossopharyngeal nerve. Now coming to the radiology to visualize the jugular foramen. Again, I have described it earlier in the discussion of the jugular foramen. We have this clivus here. This is carotid canal. This is pars vascularis, and this is pars nervosa of the jugular foramen. Now, this FaceTime image is showing the skull base that shows the glossopharyngeal nerve. So these are the glossopharyngeal nerves. This is the medulla, and we can see that it is going laterally in order to exit through the jugular foramen. So this is all about glossopharyngeal nerve. Now coming to the vagus nerve, we are again going to discuss functions, anatomy, and radiology. So this is the brainstem. These are the brainstem nuclei of the vagus nerve. We can appreciate the nucleus ambiguous, that was a motor nucleus, of spatial visceral efferent that was responsible for motor components of all the muscles that arise from the brachial arches. Then we have dorsal nucleus of vagus, having two types of fiber that are general visceral efferent. These carries parasympathetic outflow to the heart, respiratory tract, and GIT. And its other component is general visceral afferent that carries afferent visceral sensations from the pharynx, larynx, and trachea all the way up to the dorsal vagus nucleus. Then we have nucleus of tractus solitarius. These are the spatial visceral afferent fibers that carries taste sensation all the way up to the nucleus tractus solitarius in the brainstem. Then we have general somatic afferent fiber that carries somatic sensation from a small external part of the ear, and it is going to meet spinal nucleus of the trigeminal nerve that we discussed earlier is the chief nucleus responsible for sensations, somatic sensations. So again, dividing the functions, we have a spatial visceral efferent, so the nucleus ambiguous muscles of the pharynx and larynx that originated from the brachial arches. Then we have general visceral efferent, that is basically the parasympathetic outflow. These are the preganglionic fibers and goes all the way to the heart, lung, GIT, and synapse in the ganglia that are already present the wall of these viscera. Then we have general visceral afferent, the sensation from the pharynx, larynx, trachea, esophagus, and the abdominothoracic viscera to the dorsal nucleus of the vagus. Then we have spatial visceral afferent fibers that carries spatial sensations like taste from the posterior most tongue to the nucleus of the tractus solitarius. Then we have general somatic afferent that carries the normal skin sensation of the small part of the external ear to the spinal nucleus of the trigeminal nerve. So anatomical course, like we have already discussed the origin, it arises as 8 to 10 roots from the post-olivary sulcus of the medulla oblongata, travels in the cerebellomedullary system, passes through the pars vascularis of the jugular foramen and gives a superior ganglion. And just after exiting the jugular foramen, it gives an inferior ganglion, and the main trunk is going to continue in the neck and thorax and abdomen. That is obviously we are not going to discuss in the cranial portion of vagus nerve. So again, we can have the origin of the vagus nerve. Again, the similar diagram, anterior-posterior brainstem view. So the highlighted version is the vagus nerve. So this is a closed inset for the vagus nerve here. This is the vagus nerve arising from the, this is post-olivary sulcus. So we are going to highlight it. This one is 9th cranial nerve. This is 10th cranial nerve. And this one is spinal accessory or the 11th cranial nerve. So this is the left posterior view of the jugular foramen after dissection. So this is the region of jugular foramen. This is intrajugular part of jugular foramen. This is sigmoid part of jugular foramen. And this one is petrosal part of jugular foramen. Like we discussed, these cranial nerves 9, 10, and 11 are going to exit the cranium through the jugular foramen. So again, this is 9 going to traverse through the jugular foramen, pars nervosa part, and then we have 10 and 11 cranial nerve going to pass through the jugular foramen through the pars vascularis part. So again, we have dissected the lower part of the jugular foramen. So we can actually see the transit of the nerves through these foramen. So this is the glossopharyngeal or the 9th cranial nerve. It's going all the way. This one would be the part in the cerebellomedullary system. This is the region of jugular foramen, and this is going to exit all the way down. Then we have, and obviously, like I mentioned before exiting the skull, it gives rise to tympanic branch of the glossopharyngeal or the 9th cranial nerve. Then we have the 10th cranial nerve, and here it gives rise to auricular branch of the 10th nerve. Then we have the 11th cranial nerve. So all these, so all three of them are going to pass through the jugular foramen. And then we have the hypoglossal nerve that is not going to pass through the jugular foramen. It has a foramen or the canal of its own that is known as hypoglossal canal that we are going to discuss in its section. So this is the radiology coronal cut. We can appreciate at the level of the jugular foramina. This is the jugular foramina, and these are the arrowhead showing this bastoid antrum, and this will be the region of jugular foramen. So now we can appreciate the fiesta images at the level of medulla oblongata, and we can appreciate the bilateral vagus nerve arising from here and going to pass into the jugular foramen. So
There
now
again, please just raise your voice. Some people cannot hear you very well, please. Thank you. Come closer.
Closer to
Thank you.
So now we are going to have a discussion about spinal accessory nerve. Obviously, we are going to discuss the function, then anatomy and the radiology. So this is the nucleus of the spinal accessory nerve. Like I explained earlier, the spinal part of the spinal accessory nerve nucleus lies within the initial 5 segments C1, 2, 3, 4, 5, from where it arises at the rootlets, soon joined together to form a single trunk, travels behind the dentate ligament in the spinal cord, and then enters the foramen magnum behind the vertebral artery. And it is comes in close proximity with the cranial part of the accessory nerve. So we can see it is mainly responsible for the general somatic efferent. General somatic efferent, like for the muscles that develop from the somites. So it is responsible for the motor component of the sternocleidomastoid muscles, and obviously the cranial part that is responsible for the muscles of palate, pharynx, and pharynx. So we have special visceral efferent fibers. So the nucleus ambiguous going to supply the muscles of palate, pharynx, and larynx, and then we have general somatic efferent that arise from the spinal nucleus of the accessory nerve, going to provide motor component to the trapezius and the sternocleidomastoid. So anatomical course, as we have discussed earlier, arises as a 4 to 6 nucleus just below the vagus nerve, leaves through the middle compartment of the jugular foramen as a single root, joins vagus. So this is the cranial component. We are going to discuss spinal accessory nerve. As I mentioned earlier, the cranial component arises just below the vagus, where the spinal component, cranial component is just arising below the vagus, whereas the spinal component is arising from the initial 5 segments of the spinal cord. The spinal accessory nerves arise from here and goes in close proximity with the cranial counterpart. And like I explained earlier, this is going to ascend into the cranial cavity through the foramen magnum behind the vertebral artery. And then this is going to exit through the jugular foramen along with its cranial part through the pars vascularis. So this one is the cranial part, and this would be the spinal root. So here we can appreciate the small rootlets from the superior cervical spine arising, and they are going behind the vertebral artery, and there would be some level of jugular foramen. Again, this is anterior dissection of the clivus, showing the brainstem, vertebral artery, basilar artery, pica. This one is glossopharyngeal, and this highlighted one is the 11th cranial nerve. So again, I have highlighted the similar diagram showing the spinal accessory nerve going to exit through the jugular foramen pars vascularis part. And now again, we can appreciate this one is the 9th cranial nerve, this is the 10th cranial nerve, and this one is 11th cranial nerve passing through the jugular foramen. Now coming to the hypoglossal nerve. So hypoglossal nerve nuclei lies in the brainstem and is responsible for the muscle supply of all the intrinsic muscles of the tongue, as well as the extrinsic muscles of the tongue, except for one single muscle that is palatoglossus and is supplied by the vagus nerve. So the functions only includes general somatic efferent. General somatic efferent means it is going to supply the motor component for the muscles that arise from the somites. So it includes all the intrinsic muscles, all the extrinsic muscles of the tongue except for the palatoglossus. These fibers originate in the floor of the fourth ventricle So this is the floor of fourth ventricle. This rhomboid fossa or the diamond-shaped structure is the fourth ventricle, and this there would be some stria medullaris that demarcates the pontine and medullary part of the floor of the fourth ventricle. This is sulcus limitans. There would be somewhere facial colliculus and eminence due to the winding of seventh nerve fiber around the sixth. But this is not our topic today. We are going to discuss about this region. This is the hypoglossal region in the floor of the fourth ventricle, and this part of brain stem, the nuclei of the hypoglossal nerve rest. So the fibers move within the medulla oblongata to get exit from the lateral margin. So here we can appreciate the fibers of hypoglossal nerve arising from lateral side on the both sides. Again, this is again a clavicle dissection, close view. Here we have vertebral, this is basilar artery, then we have 9th cranial nerve, then 10th cranial nerve, and 11th cranial nerve. And we can appreciate this sleeve on the right side as well as on the left side, and through which this structure is passing, that is hypoglossal nerve. Now zooming in to the left side, we can appreciate this sleeve is hypoglossal canal, and these are the trunks that are going to merge and exit through this hypoglossal canal. So this is hypoglossal canal, and these are the rootlets of the hypoglossal nerve and going to exit the hypoglossal canal. So this is a CT scan bony window showing the showing at the level of the hypoglossal canal. We can appreciate this is nasopharynx, this is mandibular condyle, this is clavis, and this region is hypoglossal canal. And now again, we can appreciate this MRI. So this is at the level of medulla oblongata. We can appreciate the left vertebral artery and the right vertebral artery, small black dots, and it is going to give rise to pica over here. And this arrow is showing the hypoglossal canal. And these are the internal carotid, and this is clavicle part, obviously. Now again, the same level we can appreciate, these are the vertebral artery, and this is internal carotid artery, and this is left hypoglossal nerve originating from the medulla and going all its way into the hypoglossal canal. And this again is the hypoglossal canal, showing we cannot actually appreciate the nerve within it, but this is the region where hypoglossal canal lies. This is clavis and this is medulla oblongata. I think that's all for the radiology of the hypoglossal canal and nerve. And I think that's all for the anatomy of the cranial nerves. And Dr. Pablo will probably going to provide the pathological images regarding these nerves and the clinical syndromes and pathologies of the cranial nerves. So, so here is another slide. This is showing hypoglossal canal. This is internal carotid, jugular foramen, and then you have the sigmoid sinus. So that's all for today about the anatomy and radiology of the lower four cranial nerves. And thank you very much.
Thank you, Uzair, for this presentation. I think you gave a good presentation, but your heart is more attached to the other cranial nerve. You gave an introduction on all the cranial nerve nicely. That was covered 3 hours last week with Pablo and your colleague. But it's always to give an introduction before you start. But focus is the name of the game. When you give a presentation and you are focusing on the lower cranial nerve, try to make the focus, don't go back and forth to the other cranial nerve, because it will distract some of the audience that they are coming specifically to hear from you about the anatomy of the lower cranial nerve. All right? But it's a good presentation, and I give the venue now to uh, Pablo to cover the clinical aspect and some real cases as a correlation. Thank you.
Thank you, sir.
Thank you, Said. And congratulations, it was very dense, but a lot of information we can squeeze from it. Especially the radiology part, I really liked it, because sometimes it's so difficult to see the nerves and the relationships with the tumors we are dealing with, that you did it in a nice way. So thank you and congratulations. And last week, we were covering the middle section, cranial nerves, and I would like to share one case related to that area. So let's start. This is what we have been covering in these 3 sessions. We started with the, let's say, supratentorial cranial nerves, then we covered the superior and middle aspect of the posterior fossa ones, infratentorial ones, and now we are dealing with sections or sectors 3 and 5, which is the focus today. But let me start with this case that I was wondering to share with you, because we had many doubts before dealing with this case. It's in March 2016. This guy was 12 years old, and he had a problem when he was a baby, newborn, due to an antibiotic. He had a serious problem on the left side, so he was completely deaf on the left side. And then 12 years later, when he was 12 years old, he started having problems with hearing function in the right side. And this is the image we were observing. So at that time, I decided to do a genetic analysis just to cover that this guy was not having neurofibromatosis. It was completely negative. And in the meantime, I did a new follow-up because it took too much time. We don't have that analysis in my city. So finally, he came 6 months later with a new MRI. And this is what happened only in, let's say, 9 months time. So the tumor was double size. And we are dealing with the anatomy, but we have experts here with us today. And I would like to know their opinion about how to manage this patient. We have Imad, we have Salman, Chandra, we have Miguel. I don't know what would you do with this case. It was very difficult for us to decide if we should go for surgery or do radiosurgery. I'd like to know your opinion, if you don't mind.
Okay. Well, so I will take the privilege as a moderator for this session, unless my colleague they want to take. But you see, a patient who has lost already hearing on that ear, young chap, I'd like to have a histology on this one, and I want to take it. Even I can make a genetic studies on the tissue, and I'd like to take it out. I'm not going to lose much, but we have to be careful with the facial nerve, because you don't want to add the facial nerve on this. But a small lesion like this, intracanalicula, I think you will be able to save hearing. The other things, radiosurgery is a trendy nowadays, but you see the time span of survival. This guy, he might live another 45 or 50 years. And we don't know what is the late effect of radiation, like a secondary development and other problems that he will be having. And if he got any other lesion, we don't have the histology. The other thing, this histology will help his peers and his brothers and sisters or in the family, that they can be monitored if it's needed. So this is my approach in this case.
Thank you. Thank you. So I'm very lucky.
Chandra, want to?
Chandra.
Well, I would just like to know, Pablo, what is the level of hearing? Is it a useful hearing for the boy?
Well, in the left side, it was completely deaf. No hearing in the left side. And in the right side
of the lesion now.
Say again?
On the side of the tumor now.
Yeah, on the side of the tumor, when he came to our department, he was like, if I remember well, 25% hearing loss in the right side, and it didn't worsen too much when I saw this image. But the volumetric analysis gave us that the tumor was more than double size in volume, and it expanded the internal auditory meatus in 9 months. It was something quite rare. But the hearing function in the right side, it was 25% diminished when he came at that time.
So I agree that he needs to be treated. I think there is a equipoise. You could treat this with surgery if you are very good with hearing preservation, if your record of hearing preservation is good, or you can treat him with 12 gray radio surgery as well on gamma knife. I think the chances of hearing preservation are equally good even on that.
So I was saying, thank you, Chandra, that I'm very lucky because I asked this to Imad. He will not remember that, but we have a WhatsApp group together. So he was giving me this opinion also 3 years ago. And I was asking also to some good colleagues with gamma knife and so on. And finally, we decided to try to take it out. So I will show you how we solve it. And but for this area, I'd like to do a quiz with some of our young colleagues. I don't know if some of our young colleagues could help me solving this quiz. So Salman, can we ask someone to?
Yes, sure. Just raise your hands, whoever wants to take this, and we will unmute you. Just raise your hands who wants to take these.
This is an anterolateral superior view from the middle fossa. And we opened the internal, this is a Rhoton slide, the internal auditory meatus from above and lateral. So this is lateral in the left side, this is medial, that's anterior, and that's posterior.
We have Wael Al-Fakhawi, and I just unmuted 1 second.
So it would be nice if he can solve the lapels, the numbers.
I'm unmuted him, he's muted himself again, so I don't know. Let's give it a go again. Yes, Wael, would you like to take this? Oops.
Don't be shy.
Yes, can you hear us? No, I think he doesn't want to. He's muting himself, so it's okay. Anybody else wants to take it? All the other people who have just gone through all these nerves just now, we've just done it. Anybody raise your hands? So Parvat, our famous friend, he's been helping us. Yes, Parvat, go on.
Okay, sir.
Let's go.
So just you have the numbers in front of you and you just go through those numbers. What do you think they are?
No.
Okay, you want to take the nerves at least? Take the nerves with their numbers?
The 2 is the 2.
Yeah.
2 is the 7th cranial nerve.
Perfect.
And the 6 is the genicular ganglion.
Great.
7 is the longitudinal part of this 7th cranial nerve.
Which part, sorry?
Longitudinal. First genu, then longitudinal part, second genu, vertical part. It is the horizontal. It is the longitudinal part.
It's running medially, you see?
Yeah.
The floor of the middle fossa. This is GSPN.
Okay, sorry. It is GSPN. Yeah, sorry.
Perfect.
Then
so let's go to the rest of the nerves. So if this is fascial, which one is
this 9?
This is the internal auditory meatus, remember?
Okay.
Inside the meatus. And laterally or posteriorly and superiorly, we do have superior vestibular.
Okay, we have Rajesh. So let's get Rajesh to tell us what does he think.
Good job.
Yes, sir. Good evening, sir.
Yes.
Fourth is superior vestibular, sir. 5th is inferior vestibular. The 3rd is cochlear.
Right.
9th will be the Bill's bar. 10th will be the horizontal crest.
And we are missing number 1 and number 8.
Number 8 will be lateral semicircular canal. If I'm wrong, if I'm not wrong. And one will be.
I would say it's superior, but we could have some doubts because we don't know how deep we drilled but if you have a look at it, it's coming like, I think it's superior.
Superior.
Semicircular canal. And this this structure?
One, I don't know, sir.
It's cochlea. Have a look at this image.
Ah, that is cochlea, yes, sir.
Can you see the cochlea in the MRI, T2, Fiesta, and the cochlear nerve going inside? So the cochlear nerve is going directly to the cochlea. So that's the view. Thank you so much. And in which nerve are you expecting this tumor to grow in? From which nerve?
Superior vestibular, sir.
The most common one.
Yes.
Very good. Thank you. So that's the anatomy. And you brilliantly explained as the Bill's bar, transverse or horizontal crest. So this is the inner aspect of the internal auditory meatus, exactly where the tumor is growing. And this is a lateral view. This is the surgical view we will have from a posterolateral approach. A retrosigmoid approach will give us this view if we drill the lateral wall of the internal auditory meatus, which is what we want to do in this case. So this is a simple retrosigmoid approach to try to solve that case. And we were monitoring 8th nerve, 7th nerve, obviously. We release CSF, we do a small dural opening, and then once the CSF is released, we opened gently, following the sigmoid and transverse sinus. And here we have petrous dura. We are cutting it. We can see perfectly the nerve, so it's not a big deal. And then we start drilling the lateral wall. And it was something curious because during the drilling, just with the drilling, our neurophysiologist told us that the hearing function was improving. This is the first time I see something like that. And this is the tumor. You can see the tumor, superior and inferior vestibular nerves. So that's the tumor arising in the cisternal part, and superior and inferior. So that should be cochlear and facial, it's anteriorly and superiorly. So we open extension of the dura inside the canal, and we do have the tumor right there. We are checking for the relative location of the facial nerve, which was superiorly, as we were expecting. And now with the CUSA, we start taking some small parts. So we have the cochlear nerve right there. This is the superior vestibular, which is clearly the origin of that tumor in this area. And we are moving now to the depth. And now we are introducing the 45 degrees scope to check if we completely remove it. We can see the bed of the tumor, but there was some tumor remaining in the fundus, which we couldn't see it properly, but with the help of the 45 degrees, and I took this from Imad also, he's the one who teaches me that trick, you can see hidden corners with the 45 degrees endoscope. And this superior, again, inferior vestibular nerve, we open the meatus, and finally, the hearing function was preserved. We didn't improve it, finally, when we did the 2 months audiometry. So that was the result. This is the drilling in internal auditory meatus, and these are the nerves. And the histology was a simple grade 1 schwannoma with no specific differences to a single one. We were expecting some mitosis on a kind of aggressive tumor, but the pathologist didn't give us that information. So case 2, and now we are moving to the lower cranial nerves. This is a lady who gave me a nightmare.
Pablo, I just want to commend you that, you see, this is what it helps to save hearing, because if you wait it longer and the tumor is bigger, you might not be able to do that. The other things you have shown a small trick that I like to use as well. Before you open the dura, you made that small basal opening to release the CSF, so you won't get, especially when you are doing a bigger tumor, so you won't get herniated or prolapsed cerebellar hemisphere. So start with the cistern and then you continue. Nicely, very nicely presentation. Thanks.
Thank you, Matt. So this is a 35-year-old lady who came with a very strange pain. She couldn't explain it properly. So she told me, doctor, you have 5 minutes, I can draw it. And this is what she drew. So she was mainly having throat pain, ear pain when she was swallowing. And we decided to order this MRI. And I don't know if some of our colleagues, young colleagues, could tell me if they can see something in the left posterior fossa images that could justify this pain.
Anybody wants to take this? So we are talking about left posterior fossa.
So this is the radiology that Usair explained us. So let's see if we can see something.
Yes, Parvat, you'd like to take
Sir,
this?
it looks like that such type of case, sir, we are operating one case. It looks like a glossopharyngeal neuralgia, sir. Typically, a lady coming with such type of complaint, and he said that while I'm swallowing, the pain is radiating from my throat, and it will be coming like this only. So I think it is glossopharyngeal neuralgia type of presentation.
And with this MRI, you could see something, which is the vessel you think is compressing the glossopharyngeal nerve.
Actually, sir, in the presentation also, I can't distinguish that 9th, 10th, 9th, 10th, 11th separately. Can you explain me 9th, 10th, 11th separately, ma'am? Sir?
Sorry.
And it involved that glossopharyngeal neuralgia, it is involving of this pica.
Yeah.
That fifth cranial nerve, it is the SCA, and seventh, 8th cranial nerve by the ICA, and that glossopharyngeal nerve, it is associated with the pica.
Yeah. So there was a inferior loop and quite posterior of the pica, as you can see here. So this posterior aspect of the pica in the loop was pressing directly this area here. And also it's a little bit hidden, that region. I didn't have the 45 degrees endoscope at that time, but we can even try to manage that with the microscope. So this is the anatomy that we must be aware of. The close relationship, which we do have in the second segment of pica, to the glossopharyngeal nerve and mainly to the lower cranial nerves that we can see in this dissection also. So again, retrosigmoid approach, we release CSF and we start working, opening cisterns to gain as much space as we want. Now we are cutting arachnoid. This is the 7-8 complex. Now we are going down. And we can see the glossopharyngeal nerve in the cisternal. This is the cisternal compartment of the glossopharyngeal nerve. We are going downwards, spinal accessory is here. This is the vagus nerve, the rootlets of the vagus, and we can see the vertebral artery already there. We can see the pontomedullary junction, but we cannot see properly that pica, which is compressing the ventral aspect of this area. So that's and with the forceps, we can push it anteriorly. And if we release it, it comes again to the glossopharyngeal nerve, but we were able to place that Teflon. You see the pica, that was a loop, and this is the glossopharyngeal nerve. So with the microscope, you find it difficult to get a good orientation. This is what I wanted to show you both cases, because probably an endoscope in this one could have give us a much better overview of what was going on there. I don't know if you want to comment something, your experience on this. That was my first and single case of glossopharyngeal neuralgia, but I learned a lot from that one.
Well, glossopharyngeal neuralgia is extremely rare in everybody practice, even for people that have been 35 years in practice. I've seen perhaps 2 cases, and one of them operated like what you did, put a piece of Teflon. But they are not very common. But the typical story, they come, and most of them, they try always to have a conservative treatment, which failed. And of course, it's nice that the images showed that loop, that it gave you the residence to go after it. If you didn't see that loop, perhaps you were a little bit questionable whether you would go into based on pure clinical. But this is the typical presentation. But the technique, this is what you have to do. And I think complementing this one, as you said, with an endoscope, it gives you perhaps a better visualization and the way to put the Teflon and how to dissect that vessel. But it mobilized, which is very good for in your case. Thank you.
Thank you, Thank you.
We have Miguel here. I'm seeing Miguel. Perhaps he has an input on this case. Hi, Miguel.
Hi, how are you? This is a very nice case, first of all. And I don't have much experience in decompression in glossopharyngeal neuralgia, I have to mention. Sometimes I completely agree with you. We try to treat that conservatively. Sometimes we try at the pain unit of our department infiltration of the sphenopalatine ganglion that sometimes ameliorate very much the pain. And I don't have much experience in decompression at the posterior fossa, but this is a very nice procedure. And I'd like also to congratulate Pablo for the previous case, because I think it was very challenging. And finally, if I may if I may make some comment about the previous case, I think that you did the right thing going ahead with the operation. Finally, it was acoustic neuroma, but to my mind, initial suspicion wouldn't have been that because of the image, rapid growing, and so on. And in many of those strange cases, histology at the internal auditory canal finally is not acoustic neuroma. I have operated on miscellaneous cases of cavernous angioma and a variety of cases that very frequently, and unlike acoustic neuroma, starting from the clinical point of view with facial palsy and things like that. Anyway, very nice, both cases, nice procedure, very well done.
Thank you, Miguel. So to be completely honest with you, this lady, she improved a lot in the control of pain, but she was still feeling some pain in the lateral aspect of the head and ear. And as you said, we sent her to the pain unit, and they infiltrated the sphenopalatine ganglion, and she's quite happy now with the control of pain. So it helped a lot to do combined procedures at that time. Thank you. Again, 30-something years old lady. She was operated when she was a teenager, a cholesteatoma in the middle ear. And many years later, she came referring some swelling problems, some pain also, but especially swelling troubles. And again, I need someone to help me understanding these images if they can see something wrong there.
So any takers who wants to describe these images? Come on, let's raise some hands. Or maybe we can randomly unmute Atul Goel and ask him this question since he's hiding somewhere there. But let's unmute Dr. Chirag to start with.
Okay. Salman.
Hi, Atul, how are you?
Hi, how are you, Pablo?
Hello, Atul.
Miguel, Imad, very nice to be seeing all of you, Salman.
Pleasure.
Now you have put me into a big issue now here. Let me see what is going on.
Atul,
So
why don't we get Dr. Chirag to give his comments, and then since we're getting the trainees, and then you as an expert when you tell us. Yes, Dr. Chirag.
Okay.
Yes, good evening, sir. This is the MRI T2 trajectory axial imaging at the level of upper medullary cuts. We are showing one this petrous lesion just lateral at the level of jugular foramen, and it is medial to the mastoid, and so that is a and the lower cranial nerves are at just in the medial part and little anterior part to it. In CT scan, there is a destruction of the petrous bone at the level of jugular foramen with a smooth margin anteriorly.
Very good. And something interesting. Sorry.
Yes. And it is located in the mostly in the petrous bone. And you can see here there is a opacification of mastoid air cells in the right side compared to the left side. Yes.
Very good point.
Yes.
Very good. And this is an angio CT.
And yes, and dilatation of jugular foramen also. It's enlargement of jugular foramen.
That's it. And as you can see, the junction of the sigmoid sinus and the jugular bulb, you can always go to the right, to the healthy side, to the left side in this case, to check how the normal anatomy is. We have the sigmoid, we have the jugular bulb, and in this case we have, and the tumor is pushing this junction. So we have the jugular bulb and sigmoid sinus completely distorted due to this. It was a cholesteatoma, so probably it's a recurrence of this tumor, late recurrence of that tumor. So this is the area you are perfectly describing. So you can see with petrosectomy, we do the mastoidectomy and we go deep. This is the brainstem, so that's the jugular foramen. So here we have how these nerves are located in this jugular foramen, and the tumor is growing just laterally to them. So it was pressing not only the sigmoid, as we can see in the angio CT, but also the nerves, and this could probably justify the symptoms of this lady. And if you are still there and you want to help me with this quiz, you will be so kind.
Yes, I can do that.
Okay.
Yes.
Let's check.
The first one is the like the supravestibular nerve. We can see here.
Very good.
Second one is the labyrinthal artery. Sorry, ICA, possibly. Third one is the glossopharyngeal nerve exiting from the glossopharyngeal meatus at the jugular foramen. Sixth one is the vagus nerve going to the pars nervosa, pars venosa. Fifth one is the vagal meatus exiting from the seventh one is the 11th cranial nerve, spinal accessory exiting from the jugular foramen. Seventh and eighth both.
Brilliant. Yes. So this is the difference in between the accessory and spinal. So one is coming from the foramen magnum upwards, and they are joining together right here in the lower aspect of the jugular foramen. Brilliant.
Yes.
This is the anatomy. If we go through the petrous bone, this is the anatomy we will see. So the brainstem has been removed in this picture, and the same anatomy is explained. So this is the location of the tumor, and here we can see the inferior petrosal sinus right here, which is mainly located, as Usaid explained us, in the pars nervosa, and here we do have the pars vascularis with the jugular valve. So that's the anatomy we must be aware of. And this is a nice drawing I googled, and I found it very, very interesting because this is mostly the location of our cholesteatoma. So we are expecting to have the fascial nerve just lateral. I don't know if you can see it. This is the fallopian duct, and here we do have the tumor just medial to it, in between the lower cranial nerves and the mastoid segment of the fascial nerve. So this lady had a transmeatal resection when she was a teenager. So doing the exposure of the mastoid. So this is superior, this is the inferior, this is the mastoid tip. So this is the location of the external auditory meatus. I accidentally opened it because it was without mucosa, with epithelium, inside. So I could see the external auditory meatus through this area. This is the location of the so-called spine of Henle, and this is why I cover it with some surgical angiodyne solution. So we do a bar hole, usually at the level of the asterion, to get a good orientation. You can see the external auditory meatus, I was explaining that, and then we do the mastoidectomy from this posterior bar hole, and we will enter the middle ear, but we want to skeletonize a bit the sigmoid sinus, and we are looking for the fascial nerve, for the mastoid segment of the fascial nerve. So this is the presigmoid dura, and you can see we are stimulating also with the drill, so that's quite helpful, looking for the mastoid segment of the fascial nerve. But we found it a response right here, so this is why we were working behind it, and we were checking all the time the relative location of that fascial nerve. Then we went deeper to the jugular foramen. This is the intrapetrous part of the jugular foramen. We had some CSF. This is the glossopharyngeal nerve. We check it with the stimulator, and with this speculum we were able to have a look. So that's the jugular valve, and now we have to try to gently take it out from the mastoid segment. This dissector is stimulating also, so it's also being very helpful, and we are trying to skeletonize that mastoid segment of the fascial nerve, which is right there, covered by a very, very thin layer of bone, and that was the glossopharyngeal nerve going through the jugular foramen. That's the jugular valve, and we are covering with some glue and the spongostan and some fat later on to try to prevent that CSF to go to the external auditory meatus, because you realize that we opened the external auditory meatus from inside. So we wanted to be very careful about that. And in these cases, I use sometimes some bone wax or some cement, which is very helpful to prevent that CSF. And that was the result of the resection. And the fascial nerve was intact, which was one of the goals of that one. I don't know if you want to comment something on that one. Salman, Matt.
Atul, your comments, please. Let me just unmute Atul. Yes.
Yes.
Oh, okay, Salman, you want to comment, or should I proceed with some comment as well?
Atul wanted to comment.
I have a tool. Yeah, let's have a tool.
Yeah. No, this is very well done. You see, this this tumor is Indeed, cholesteatoma, there is no question, but it is very close to other anatomical structure. Pablo, you will like to show in this situation is just lateral to the cholesteatoma will be endolymphatic duct and sac. Do you think it has some anatomical relevance? Exactly, it is in the location of the endolymphatic duct and sac. What do you think? What do you have to say about that? Just lateral to the...
Sorry. Yeah.
Did you hear what I said?
Yes, perfectly. Sorry. I was saying that that's a perfect comment, but I'm looking for the CT scan because I think I didn't include too many slices, sorry. So the endolymphatic duct is the connection, in the petrous dura, in the presigmoid dura, we have a kind of fold which is joining this dura layer running directly to the labyrinth. So this is the connection in between the labyrinth and the presigmoid dura or the petrous dura in the CP angle. Generally, it can be even visualized in a good CT scan. But here the thing is that the petrous bone was quite destroyed, and the labyrinth was destroyed also by the tumor itself. Probably in the previous surgery, because the ENT surgeons did a transmeatal resection, so probably they drilled even the labyrinth. So it couldn't be very, very well understood, that region there.
What was the hearing in this, Pablo? Do you have the hearing situation in this patient?
It was lost completely since he was a children. It was completely lost, that one there.
So you have to explain to me why the hearing is lost, whether it is the nerve. See, the nerve, the cochlear nerve is completely intact. There is no problem with the cochlear nerve.
The thing is that
the problem is with the labyrinth and with the endolymphatic sac and duct, which can lead to hearing loss. You see here, if you see the cochlear nerve is intact, there is no problem with the cochlear nerve. The problem is with the rest of the situation, the labyrinth and the endolymphatic sac and middle ear. The middle ear also is gone here, middle ear.
Yeah.
So it is not a nerve deficit, but a conductive deficit. Maybe after this removal, the person might improve in the hearing.
The thing is that I don't know, if, Professor Goel, if you were there at the beginning of the case, but this lady, she was 35 when she came to us with this image, but she was operated when she was 13 or 12 years old. She had a cholesteatoma in the middle ear at that time, and I don't have the images of that previous surgery, but they did a transmeatal approach, classic ENT approach, and they drilled the middle ear. So this is why, and probably also the labyrinth. So this is why she was deaf in that side since she was a child. But I got your point perfectly. Yeah. It was a conductive deafness.
Yes.
I have one question to all the faculties. Will you consider the possibility of a small retrosig approach to this one where the bone is gone? Because I confronted with the similar case, and we went retromastoid, and I just have a dura to incise, and I am at the lesion, and I could correct this lesion out without the hassle. I know I like the pre-sigmoid approach, but sometimes it's very limited. It depends on the dura and lateral to the sigmoid sinus. If you have a good dura, yes. Sometimes it's a hassle to find the treatment triangle or to find adequate treatment triangle. Of course, for this lesion, cholesteatoma, they are nicely resectable. They are not a vascular lesion that give you hard time. They are not adherent in general. I don't know with this one as a recurrence, but a retromastoid, it gives you directly on that area. Of course, you have to be careful with the cranial nerve, but usually it widens the jugular foramina as it shows here. There is no bone over the jugular, completely widened, and a small incision in the dura you are in, and we do it with the stimulator, as I said. Just a short comment. I don't know what is the opinion of the others.
Yes.
I think for this, as it is an extradural lesion, I think the approach which was taken probably seems to be the more correct approach, because whatever said and done, while trying to get the two layers of dura, the inside dura as well as even though the bone is destroyed, I'm sure there will be periosteal dura there. To incise that, you run the risk of damaging some venous channels, and in addition to that, I think you are exposing this patient to aseptic meningitis. So I would prefer an extradural approach. That's what I feel.
Yeah, that's sensible. Totally agree. Yes, Miguel. Sorry.
No, yes, I do agree. Well, all road led to Rome, but I think this is a primarily extradural approach, and I think this approach through the mastoid area is a very straightforward to my mind. I like the way Pablo managed all this structure, and because this is a very difficult area for benign lesion. Jugular foramen is really difficult sometimes in order to preserve nerves and things like that, and critical structure. And I do agree. I would have gone through extradural route.
The good thing, thank you all. The good thing about that one is that it's a tumor growing in the bone, in the petrous bone, so it's completely extradural, and that it's pushing the external dural layer, which is covering the sinuses. So in my mind, it was the most, let's say, safe approach to go directly through the bone, through the mastoid. And even the most inferior aspect, caudal aspect of the lesion was posteriorly covered by the junction of the sigmoid sinus and the jugular valve. So that could be reducing our approach if we go intradurally and then we go extradurally. So we could probably have a quite narrow space. It was nice discussion. And I have a couple more cases, but this is the one with which I just wanted to finish because it's a quite interesting one. This is the lesion that a patient came to the clinic referring very, very uncomfortable and progressive instability and progressive hearing loss in the left side. So it's an arachnoid cyst, and the interesting thing about this case, I don't know if you remember that in 2004 we had a terrorist attack in Atocha in the station, and that was before, which everything is very in place, everyone is calm, and we can understand the anatomy of this region. But sometimes when we have a tumor there, all the nerves get crazy. And this patient was in one of the trains, and he had a subarachnoid, post-traumatic subarachnoid hemorrhage in that accident. And he came with this MRI 12 years later, if I remember well. I was able to have a look at the CT scan that he had during the traumatism, and he had no cyst. So in my mind, this could be a post-traumatic arachnoid cyst because it was not before the subarachnoid hemorrhage that he had. And in 2008, he had a control MRI because he was feeling some headache, something like that. And we saw the cyst already there, very small one, but it was growing, progressively growing. So that's why we offer surgery to this patient. And in this case, we decided to do a retrosigmoid approach. We just need to fenestrate all the layers of the arachnoid cyst in between all these nerves. And the fact I'm sharing this case with you is because we will see a crazy anatomy of all the nerves that we have been reviewing. So this is the lateral wall of the cyst, the posterior wall. That's the tent, the tentorium. This is Julia, our nurse. And we can see in the right side, we have the tent, anteriorly the petrous dura, and we are cutting a purely endoscopic approach with the working channel. This is the neuroendoscopic approach we use for third-ventriculostomies. We are cutting all these additions. So we have the 6th nerve, we have the 5th nerve, 7 and 8 nerves. We are going even downwards through a very small retrosigmoid approach to the level of the foramen magnum. And once we did all our sections in this arachnoid cyst, this is the crazy anatomy that we were watching. So let me see if I have the levels for that one. And this is what I thought. So fourth nerve, fifth nerve, 7 and 8 nerves, which were pushed, 6th nerve going up, glossopharyngeal nerve going directly to the pars nervosa, and 10th, 11th nerve going to the pars vascularis. We have the glossopharyngeal nerve that, as we recently discussed, is just posterior to the vertebral artery, and we can even have a look at the foramen magnum. So this is the medulla oblongata protuberance, and this is the 10th. So that was the last case I wanted to share because it's summarizing all these anatomical structures. And I thank you so much, Salman, for having me in this Rhoton club. I really enjoy it, and you are making a big difference in education. Thank you so much, Salman, for that.
Mad, all yours.
Well, wonderful presentation, and that conclusion with the endoscopy. I'm sure Dr. Chandra will be happy to see these images of the endoscope. Very well done. Of course, for a big cyst for me like this, I want to do a big craniotomy. I have to tell you, if I'm going to do the endoscope, I will make it smaller. But it's a good demonstration, Papa. It's a wonderful as usual. I thank all the faculties for their input and their contribution. It was a nice discussion. Thanks to Atul that he joined us from California. Okay, with the I insist on him. I would like to see the great Indian gate behind him next time. Pablo, Miguel, and I leave the venue for Salman to conclude.
Okay, we're just going to have the multiple choice questions to follow. I don't know whose questions are these. Pablo, are these yours or are they from Uzair?
No, Uzair is the one.
Uzair, are you there? You want to take these and take us through these? Uzair, are you there? Uzair,
yes,
okay, go on. So you can take these.
Regarding brainstem and cerebellum, which of the following neurovasculature complex is correct? So, I'm having some issue with the laptop here. Imad, have you given me access or?
Imad, can you help?
You are going to scroll the page for me.
Yeah, I am going to handle this.
So please show me the options.
You have the options in front of you, 4 of those?
No, sir, I can only, yes, now I can see. So the correct answer was posterior inferior cerebellar artery, inferior cerebellar peduncle, medulla, and the lower 3 cranial nerves. So the diagram I've already.
So can we show the diagram again?
Section.
Just, yeah, you can enlarge this and show this.
So Imad, kindly enlarge the diagram.
I have to.
Okay, it's fine. We have seen it quite a few times. It's okay. Let's go on to the next question. So it's simple question. Go on.
So yeah, this was a very simple question. Contains a structure passing through jugular foramen, includes all except, we all know, hypoglossal nerve that has a sleeve of its own and a canal of its own. So hypoglossal nerve passes through hypoglossal canal and all the others through the jugular foramen. This was, I think, a difficult one. Regarding brainstem nuclei and functional modalities of the cranial nerves, which one of the following is correct? So, answer was, yeah, the answer A was right. The general somatic efferent for the extraocular muscles and all the intrinsic and extrinsic muscles responsible for the general somatic efferent. Imad? Hello, Imad, can you hear me?
Yes, we can see both of them on right and left. I'm sure you can see as well.
Yes, sir.
Okay, so can you label the highlighted one?
So this one is the highlighted one, and this is obviously anterior inferior cerebellar artery, and its complex, including this one is abducens and this one is trigeminal.
Very good. Okay.
So 56%. Yes, yes, this is obvious going through the hypoglossal canal or the sleeve-like formation. Although this is hypoglossal nerve. So 54.5% gave the correct answer.
Jose, you have to teach them again because, you know,
So I think this was a pre-quiz, if I'm not wrong.
Oh, we are doing the pre-quiz. Okay. All right. So it's fine. So we have seen the questions. Anybody wants to ask any questions? I saw somebody has, Lee, do you want to ask a question? Can I'm unmuting you if you want to ask a question. I don't know. I can't unmute. Can you please unmute Lee or Peer? Either one of them? Imad?
Sir, I'm doing it, but they have to unmute themselves as well.
Okay, no worries. So
yeah, they are unmuted. They are unmuted.
Yes, Peer. No, they came and they disappeared. I don't know. Yes, Peer.
Yeah,
Can you want to ask a question? Hello. I think it's probably by me. I don't know. No worries. So I'm grateful to everybody. We can have.
Salman,
yes.
before you come with this announcement, I just want to remind the resident, anatomy does not stop at the skull base. You have to remember this cranial nerve, they continue their journey. You see, you are a surgeon and sometimes you do neck dissection within ENT. Sometimes you do cervical disc. You have to be looking for the 10th nerve with the recurrent nerve. Sometimes you expose the anterior scalenus for the 11th nerve. So be careful and understand the anatomy beyond the skull base of this cranial nerve. So I just want to give this message. Thank you.
Sure, sir.
Okay, so tomorrow we have Salim Abdurrauf talking about awake brain surgery. Vlad Beniz is the moderator with him, and Athar Inam from Karachi will be talking about some cases with that. Imad, do you have more stuff, or is that we have for?
No, sir.
Okay, so we will keep you posted. The following Saturday, we have the WFNS Endoscopy Committee and IFNE session as well, and we have 2 sessions in between as well, so we'll keep you posted. So I'm grateful to everybody. Can we all switch on their video so that we can have a group photograph, and then we can wrap up. And if Chandra, you'd like to say a few words before we wrap up. Thank you.
I think this has been an excellent program. I think the brain sessions were very good, and the cranial nerves have been special as well. So I congratulate Salman and of course Pablo and Imad and other senior members who have contributed. And I think it has been a very good program, and I hope people take advantage of this. Like Salman said, that 50% right probably is not good enough. So I think it's time to go back to the drawing board, have a look at it again, and always think about it when you see cases. So that's going to result into the ultimate success. So thank you once again, Salman.
Thank you. Miguel, your few comments. We just wrap up.
Thank you. Very short comment. First of all, just to congratulate. I think one of the interesting things of this educational format is the possibility to look at the anatomy, at the neuroanatomy, microsurgical anatomy, and at the same time, the possibility to combine that knowledge with real practical and difficult cases. I think this is one of the key points of this activity you have planned, and I'd like to congratulate for the way of doing that, of combining that. I think that neuroanatomy more and more has been something presiding courses, activities, and the way of learning for young and senior neurosurgeons. And Salman, I do congratulate you on this wonderful activity. I have the honor of having Imad Kanan, the chairman of the WFNS Neuroanatomy Committee among us, also Pablo, Gonzalez, very much involved in that committee, Dr. Deo Pujari as chairman of the Neuroendoscopy Committee, and I think of this constellation of stars contribute very much to the success of such a wonderful course. I had the opportunity to be active, presenting cases and making some presentation about my activity, clinical activity. I'm very proud, I'm very happy, and thank you very much, and congratulations again, Sam, my dear friend.
Thank you, Miguel. I think it's all because of all of you. I think the giants of neurosurgery are sitting here giving comments and teaching us. Is amazing. I'm grateful to all of you. Imad, you're the moderator, so you can wrap this up. Thank you.
Well, I'd like to thank again everybody, and specifically Salman, for this initiative, which has been wonderful, and I've been part of several sessions, and all my colleagues speak highly positive about this activity. You have thought ahead of anybody about it, and for the sake of bringing a new generation of neurosurgeons that are acquainted with the good neuroanatomy, not only practical, and bridge the gap to practical neurosurgery. It's like Professor Chandra, he is again, he is a major contributor for the this activities. Miguel, as usual, has been very cooperative and very active. And Pablo, of course, he is I call him the Da Vinci of anatomy and this contemporary millennium. Thank you.
Okay, thank you, everybody, and especially all the residents who've been contributing in this. You've done an amazing job. I did not know this much anatomy when I was a resident, frankly. I think great job. So thank you all, and we'll see you soon. And we're going to have the next module from next week. Thank you very much. Okay, looking forward to you all again. Bye-bye.
Thank you.
Bye-bye.